As we all know, Levenick safe zone recommends us to put the cup in an inclination of 40 degrees and anteversion of 15 degrees plus minus 10. However, this paper by Matthew Abdel said what safe zone? The results were 58% of the dislocated THRs were in the Levenick safe zone. So what must have gone wrong? Most probable cause is unfavorable spino-pelvic relations. What adjustments we need to make? We have to do pre-operative evaluation very properly. We need to study the pelvic X-ray, AP X-ray properly. We also should take a standing, supine and sitting lateral radiographs of the pelvis and the lumbar spine to study the relationship. There are certain definitions which we need to understand when we want to know about spino-pelvic relations. One is the pelvic incidence, sacral slope and pelvic tilt. These are the minimum which we need to study. The pelvic incidence is the angle which is formed between a line drawn perpendicular from the midpoint of S1 superior end plate and a line bisecting the center of the femoral heads. Sacral slope is an angle between a horizontal line and a line parallel to the superior end plate of S1. And the pelvic tilt. The pelvic tilt is the angle that pelvis forms with the vertical. The mean pelvic tilt angle in the standing position is 13 plus minus 6 degrees. And the pelvic tilt indicates the spatial orientation of the pelvis, which changes according to the position of the patient. In normal spinopelvic motion, as one transitions from standing to sitting position, the pelvic tilts posteriorly approximately 20 degrees in order to increase the functional acetabular anteversion 15 to 20 degrees to accommodate the hip flexion without any anterior impingement. But when there is a stiff spine and the patient undergoes a THR, when he changes the position from standing to sitting position, that it can lead to an anterior impingement and leading to hip dislocation. Spinopelvic stiffness, when we measure the sacral slope from sitting to standing position, if there is less than 10 degrees of motion of the pelvis, then it is considered as a stiff spine. Then there is a concept of pelvis which is stuck in standing, in which the pelvis never achieves a sacral slope of less than 30 degrees in overly anteriorly tilted, or it is stuck in a standing position. The sacral slope is more than 30 in standing and sitting. In this, the implant risk for the cup is if it is retroverted. It will lead to anterior impingement and posterior edge loading, leading to posterior dislocation in sitting position. The cup positioning which was proposed is 15 to 25 degrees of anteversion in this case. When the pelvis is stuck sitting, the pelvis never achieves a sacral slope of greater than 30 degrees in overly posteriorly tilted or stuck sitting position. In this, the sacral slope is less than 30 in standing and sitting position, and the implant risk for cup if it is anteverted. It will lead to posterior impingement and anterior edge loading, leading to anterior dislocation in the standing position. Then if there is a kyphotic spine, sacral slope is less than 5 in such sittings, in a sitting position. It will lead to jump distance exceeded, leading to posterior dislocation in a sitting position. Wigdorczyk recommended the acetabular anteversion to making it to 30 degrees in this case. So we need to do alterations to the Levenick safe zone, and there is a classification in which if the spine is balanced and flexible as it is in healthy individuals, then the Levenick safe zone can be followed. If the spine is balanced and stiff, then in cases such as lumbar degenerative disease, prior lumbosacral fusion, then we need to increase the anteversion to between 15 to 25. If it is unbalanced and flexible, like in post-laminectomy or in neuromuscular disorders leading to kyphosis, then we need to reduce the anteversion. Unbalanced and stiff spine, that is long spine lumbosacral fusion, or in ankylosing spondylitis, we need to reduce the anteversion. And whenever in difficult situations where spine is fused, we should be opting for a robotic total hip replacement. Robotic THR will definitely help in such situations. This is a pre-planning video in which after doing the CT scan and studying we can enter the values of the sacral slope and the pelvic tilt in sitting position and in standing position. We can enter those values in the software, and it will tell us in which position the chances of dislocation are there. It will lead, it can give us a virtual range of movement, and one moment, it can, we can, put the limb in virtual range of movement and see at which degree of anteversion, in which degree of flexion and rotations it is going to lead to an impingement, either the implant to bone impingement leading to dislocation, and we can make the changes in the software accordingly, and we can alter the position of the cup depending on the impingement profile of the patient. So whenever there is a difficult and complex spinal pelvic relationship, we should definitely opt for a robotic total hip replacement. Thank you.